Today's webinar is the top 5 reasons practices fail CQC inspection. It's specifically based on research that we've done into CQC inspection reports, ongoing research that we're constantly doing at Code for you. And I've said the top 5 reasons and also the cause, because looking really deep into it, there's really those 5 reasons or those 5 areas where practices are failing inspection. They're kind of failing. I mean, technically the CQC used the word breach, but I'm sure all of us talk about passing or failing an inspection. But they're failing really for like one reason, or 2 reasons, or 1 cause, or 2 cause, which if you have iComply, I don't think that's going to be an issue for you, or probably won't be an issue for you. So hopefully you shouldn't have any problems. So, but we'll give you the information on this, and then let's see. As always, it's verifiable CPD. We need to have aims, objectives, and outcomes. So the aim of our webinars is to increase understanding of inspection regimes and help practices prepare for inspection. As I said before, this is specifically about the CQC. However, if you are in Wales, Scotland, if you're in Northern Ireland, our system obviously does lead to compliance in those areas as well. And the CQC are kind of leading the way on how compliance is regulated, or how the standards are regulated. So if we look at what the CQC does, generally what we find is HIW and RQIA kind of follow suit a little bit afterwards. So the information is transferable to other regions. So objectives, we're going to explore the code research. This is all based on research that we've done into CQC inspection reports. We look at every single one that they publish. We're going to discuss why practices are failing or breaching standards on their inspections. And we're going to explore how the iComply application helps you to meet the standards, how it helps you to pass inspections, and how the code team and the iComply service helps you to pass inspections as well, and what you have access to as a member. Learning outcomes, hopefully you can train your team a bit better to spot compliance issues. You'll be able to know it yourself, so hopefully some tips you can take away from this. You're going to be able to review the compliance in your practice with increased confidence. Obviously knowledge is power. The more you know, the better you can be at this. And hopefully you're going to improve your understanding of this, of what inspectors are actually looking for in your practice. So those are the goals for today. Always quite big goals for a 45 minute webinar, but hopefully you'll get a lot from this. So new focus areas. Before I jump into it, obviously at Code we have almost 3,000 practices or something like that who use one of our systems. The majority of them being on the iComply application, which is our main system. We speak to our practices before they have inspections. Quite a number of you who are in the room today have called me up and asked me how to prepare for an inspection. And I've given advice, and that seems to have worked. And then also those people who call us, then call us back when they've had their inspection and let us know what the CQC are looking at. So we get a lot of information from you. So with 152 of you in the room, wow, that's something I'd ask you, if you can help Code with that and help everybody else in the room. If you've got an inspection coming up, if you've just had an inspection, in either of those scenarios, please talk to us. Please let us know, because this is what makes the system so good. And then on top of that, we also look at all the inspection reports that are published. So we have a process in place where we're actually looking at every single report that's coming out, and we're looking for trends. So what are we spotting at the moment? What are we seeing? Safety alerts. In the iComply system, you've got M233 SAL, which is your safety alerts policy. And the CQC are picking up a lot on the fact that, say, MHRA and CAS alerts, you need to be signed up to them, but you need to have a process in place for dealing with them. So there's been quite a few in the last 12 months that have related to dentistry. I think there was a glucagon, a batch of glucagon that had faulty needles. There was some pediatric AED pads. So the CQC are coming in and asking to see, how did you deal with these alerts? And practices are falling down where they can't actually show that they did check with these alerts. They don't have any evidence or follow-up. So one thing we're doing at Code right now is we're beefing up our safety alerts policy to include a bit more of a procedure for you for how to deal with them afterwards. So we're just seeing that seems to be something that's appearing on a lot of reports. Expired materials. The CQC will go through your drawers and look for expired materials. So you should probably do the same. Sedation, there's been this whole sedation thing has been in the air about what we should do about sedation because of the guidance, and I won't go into all of it, but the CQC have published clarification of what they're looking for at the end of December. We are going to have a module out in the next month or so. But essentially, if you're a sedation practice, you need to be following the SARD guidance. That is what they're using as the gold standard, and you need to be auditing and keeping records. We're going to release a module and most likely an audit as well for you, so that's in the pipeline for you. Policies sounds really obvious, but the CQC, I've noticed a lot on inspection reports recently that if you are not regularly reviewing your policies, or you don't have proof that you're regularly reviewing them, or if your policies are not edited properly, not adapted properly to your practice, or adopted as we say at Code, then that could get you into trouble. Wrong names, if team members have left and you've got the wrong name on the policies. So a lot around policies. Obviously with the iComply system, this is standard, something you're doing every single month that you do very, very well as members is reviewing your policies and making sure they're up to date. So I don't think this is an issue with anybody here. GILIC competency. I won't go into the details of GILIC competency, but it's about when a child can consent. Or whether a child can consent. The CQC are looking for this more. This doesn't affect a lot of practices, but if you've got, say, an ortho contract, this can be something this is something we're seeing coming up more. So we are either going to adapt our consent policy, or we're going to release a specific GILIC competency policy. That's in the pipeline as well for you. Safer Sharps. Won't go into detail on this. We've got a health and safety webinar. You can watch that for details on Safer Sharps, but it is something they look at is, are practices complying with the Sharps regulations? And if they're not, how have they justified it with a policy and a risk assessment? So it's something they look at on every inspection now. They seem the Safer Sharps regs came in 2013, so they're really looking that people have dealt with it by now. Disability access audit. The CQC are looking that you are assessing your practice for access and you're making reasonable adjustments. We've just released one in the system. I don't really need to talk any more about that. It's there for you to use to generate that evidence for inspectors. Prescription pads are still a big deal. If you've got an NHS contract, then you need to keep them somewhere secure. For example, in your safe, you need to keep a log of every single serial number, which are non-sequential on the prescription pads. And you need to keep a log of them somewhere, and then if you lose them, once you use them, you need to cross off that serial number has gone. Because the idea is, if your prescription pads get stolen, then you can tell the local area team what prescriptions are out there amongst the general public, so they can tell the pharmacists. So these are things that are being picked up on. New one is CCTV. The Information Commissioner's Office, the ICO, have published guidance on the Information Commissioner's Office have published guidance on CCTV and risk assessing your practice and having the right signs up if you have it internally in the practice. So we're looking at our documents, we're looking at the guidance right now because this has been mentioned to 2 practices, members of ours, in the last 2 weeks. So reinforcing again why we'd love to hear from you and why we can react this quickly. So with almost 160 of you in the room, please let us know this information, because this is how we stay on top of it, or one of the many ways we stay on top of it for you. Future of dental regulation. I'm not going to go into this in much depth, but we're going to get new KLOEs, or the KLOEs are being redefined by the CQC. As part of consultation. They created 11 sets of KLOEs, one for each healthcare sector and care sector, and now they're trying to sort of bring them all together. Now, they've been doing it for hospitals. They've not really started the consultation for primary care yet. That will happen in August this year. Code may or may not give them some feedback, depending on what it looks like, whether it looks reasonable or not. But we're on top of this for you. That's just to let you know the GDC and the CQC are looking to change regulation. We're aware of this. We don't need to do anything yet. There are people offering training courses about this, which I think is a bit premature because nothing's been decided yet. And it's going to be for us next year, probably April next year is when it will change. So just so you know, the key lines of inquiry, Nicola, KLOEs, sorry. Are you safe, caring, effective, responsive and well led? So they're redefining what goes under each of those topics and whether they need to add to them or take away from them. So we'll look at that. But we're monitoring and we're ready to react to this. So just so you're aware. Right, so getting into the actual webinar itself. So this is all based on code research. This is how we know the top 10 reasons, the top 20 reasons, but we're going to talk about 5 that practices are failing inspection. We've looked at 1,500 inspection reports since every inspection report that we can find since they started doing them in April 2015. So up to the 27th of February. So very, very recently. What we've found is on average over that time period, on average between 15 and 20% of practices are in breach of standards, so are failing the inspection each month. That number seems to be going down. It started quite high at about 20%, and it's going down to about 16% now, and that seems to be, I don't know, maybe they're being a little bit easier on people, or maybe as a profession, we're getting to grips with the new way that they're inspecting and what the CQC are looking for. So I'm not quite sure why, but it's still a significant number, 16% on average. 70% of practices are being told that they could and they should make improvements. So not so bad that they breach on the inspection, but not so bad that they breach on the inspection, but not as perfect as the CQC would like them to be. I've mentioned this many times, and I don't want to go into it in too much depth here, but when you're sort of borderline between failing an inspection and not failing an inspection, the key thing that seems to swing it is how well governed you are, how well led you are. Was it because if this mistake happened because you're poorly governed or poorly led, then you're probably going to fail. Or if you've got a bad attitude towards the inspector, if you're treating the inspector in a hostile manner rather than being open to them and trying to sort of work with them. Whereas if you're nice to the inspector and you're well led and something has genuinely slipped, they seem to go on the other side. So just a small tip there. Most practices that are failing because they're not well led. So that's part of what we'll look at today. Is there's 5 top reasons practices are failing, but generally it all stems from a lack of governance and a lack of leadership, which with iComply and following the code system, I think most of you will have. And to be honest, this is a big piece of research we've just been doing, is that as part of this research, this data set, we looked at those 1,500 practices and we looked at which of them had iComply application. And which of them had it before the inspection and for a decent amount of time before the inspection, not just a day before the inspection. And what we actually found was, of our members, of our 800 odd practices that are on iComply application now, 37 were inspected in 2016. Every single one passed inspection first time. So that's a brand new statistic, which we've just found out we're really, really happy about. Obviously, it means that it's working. But I doubt many people can say that about their compliance systems. So we're really happy about that. So thank you all for asking us what to do and doing it and staying on top of it. So what are we trying to avoid? With the key lines of inquiry, obviously safe, caring, effective, responsive, well-led, it's really buzzwordy. So what we're actually finding is that the press love it, because if a practice fails an inspection, a report goes on the CQC website that says this practice is unsafe, or this practice is poorly managed, or it's not national newspaper worthy, unless you'll say, was it St George's Hospital that they found to be not safe and not well led, and that was national newspaper headline. But for dental practices, it's probably your local press. So this is a situation we all want to avoid, is a local press headline that says that we're not safe and not well led, because that obviously could affect our patient numbers. So what are the top 5 areas? I've not put them in the exact order, and I can't remember exactly what it is off the top of my head, but the top five areas are recruitment, specifically compliance with Schedule 3 of the Health and Social Care Act, infection control, clinical record keeping, risk assessing, and auditing. Those are the top the top 5 areas. However, all of these areas, failure in all of these areas really stems from poor governance and poor leadership. So I want to go a step beyond that and talk about the governance and leadership aspects and what we're seeing with that as well. So if we go into the 5 areas, the first one is recruitment, or the first one on this list is recruitment. It's not number 1, I think it's number 3. But the recruitment, it says here, this is a quote from, all these are quotes from CQC inspection reports and what they say. It says, review systems to ensure the practice's recruitment and policy and procedures are suitable and are in line with Schedule 3 of the Health and Social Care Act. So what it all comes down to is Schedule 3 of the Health and Social Care Act. Now, there's a lot of stuff that you need to have in your personnel files, and not all of it is a Schedule 3 requirement. So you'll probably look at this list and think, well, there's some things missing there that we need to have in our personnel files. You'll also be very, very happy to know that at Code, we are working on a whole load of new contracts for you, which are with lawyers now. We've beefed up all of our agreements. We're also working on a whole load of new HR modules and helpful sheets for you to help you, say, audit your own practice files as well. So there's a whole chunk of HR work going on with Karen and her team at the moment at Code, which you should see really soon. We're also working on version 3 of the iComply software, which quite a lot of you will be upgraded to at some point. So Schedule 3 requirements. You are legally duty bound to have certain things. So the Schedule 3 of the Health and Social Care Act, there's other stuff that you need to have in here. I haven't put, say, immunisations on this list, but there are things that you've got to have in your file, and this is really, really sort of key. Proof of identity, including a recent photograph, enhanced DBS certificates. I don't want to get into the debate over admin staff or non-admin staff right now. If you can get them for your admin staff, just get them. It's just easier. References, full employment history, including written explanations of any gaps. That's really important. That's actually written in the regulation that you must have explanations for any gaps. And in order to do that, obviously, you need to have good interview notes. So that's why we put interview notes on here. You want to at least have tried to assess or given that person an opportunity to declare any medical problems that you maybe need to reasonably adjust for them in the practice. CPD certificates, so things like, your proof of safeguarding, your proof of annual CPR, all of those kinds of things. So I won't go into much detail about that because the next webinar we're going to do, which will be on Wednesday, the 5th of April, will be with Karen, our HR manager, who will be doing a recruitment webinar on what you need to do to properly recruit and make sure that you meet not only Schedule 3 of the Health and Social Care Act, but also all the employment law that's out there. So she's going to help you all with that in about a month's time. So I'm not going to go into this one too deep, but if you get a call saying you're going to have an inspection in 2 weeks' time, one of the first things I'd recommend you do is audit your staff files, because that's a really easy way to breach on your inspection, is to be missing documents. So HTMI 105. Obviously, this has been around for so many years now. We've had HTMI 105 since, I'm trying to remember, was it 2009 it came in? When it first landed on our desks. I know that 2013 was when it was updated. Who can remember when it landed on our desks? When we were given a year to get ready for it? Was it 2009, Nicola? Okay, 2009, I remember it just appearing on my practice manager, on my desk. And it was quite an impact. It's quite heavy when it hit the desk. Okay, so HTML 105, just making sure that you are meeting HTML 105 and the code of practice. So that's really important, and the code of practice as well. So what I've tried to do is here, obviously I can't talk about everything about HTML 105, but you've got to make sure that your procedures, your written procedures document, so we've got in the code system M257B is our written procedures that you review every year. It needs to be up to date, it needs to be accurate. So if your written procedures document says that you have an ultrasonic bath and you don't have an ultrasonic bath because you've not deleted that section from the procedures, then your procedures don't match the practice. Therefore, your document isn't a real document, it's just something you've got on file to pass an inspection or show an inspector. So you need to make sure that it matches your procedures match what you actually do with the practice and that is compliant. So there are practices that are still failing inspections for not having magnifiers in the decon room, simple things like that. Doing your accurate 6 monthly audits. So making sure you're doing your 6 monthly audits, that's the legal requirement. You have to do an infection control audit every 6 months. You need to identify problems. So the person who's doing it, and this is something myself and my team come across in practice quite often, is the person who's doing your infection control audit, do they know what every question on the audit means? Have you given it to somebody who is competent enough to actually do the audit? So I'm going to let that sink in and just think about it. But just think, have you given it to the trainee nurse? Is your decon lead, is the person that as a practice that you have in your documents as your decon lead, as a practice, have you supported them enough to do that role? Are they trained well enough to be your decon lead? Or have you just made the longest standing nurse your decon lead? So I find, and my team find, when we audit practices, we do find inaccuracies on infection control audits because they're not being done by a competent person. So you need to do them every 6 months. You need to create actions and you need to follow up on those actions and share any learning with the team. I'm not going to go into that into too much detail because that's an auditing point, but that's a big thing where people are messing up. I'll come to the questions at the end because we've got a lot to cover. So if you can hold the question till the end, and then type it again when I ask for questions, then that would be appreciated. Annual statement on infection control. So obviously we have to comply with HTM 105, but we also need to comply with the Code of Practice. And the Code of Practice says that every 12 months, you need to do an annual statement on what's gone on about infection control, how your audits have gone. We have that document in the system. It's called M258A. And you are prompted to review that and update that document every single year. That's in the iComply system, it's scheduled for you. So our members shouldn't have any problem with this, but I keep seeing it pop up on inspection reports. Fully completed logs and correct testing and correct servicing. Are you getting all the correct pressure vessel tests, the annual validation, your servicing? Are you doing the right tests on your machines? Are you doing them at the right frequency? Are you logging them in your logbooks? And what happens when you've got a temp in that room? Is your temp doing it? Has your temp been inducted? So there's a lot of things there to consider, and I can't, obviously, we're doing an overview today, but this is something where the CQC find, somebody's doing a protein test once a month for an ultrasonic when it's a weekly requirement or something like that. So obviously all of this stuff and this information is in iComply, and these things are scheduled for you to make sure that you get them done. Immunisation records. Again, this is on the health and safety webinar. We went into immunisations in quite a lot of depth, but just a basic one is proof of seroconversion. So hepatitis B, I'm sure most of you know this because we've got 160 quite compliant practices in the room, but proof of injection for immunisation for hepatitis B is not proof of immunity. That's your blood count and your antibody count. So just something simple like that could mean that you get in trouble on your inspection because of seroconversion on file for a team member who is doing decontamination or seeing patients. So that's just one thing that can come up on immunisations. Okay, record keeping. And the CQC have gone round and they've been assessing everybody against I think it's version 2 of the FGDP standards, which is the standards for record keeping that we need to comply with in this country. It's the guidance, the main guidance. This was updated last year. So we've got a 2016 version 3. You'll be very glad to know that we are almost finished. We've updated our module, we've updated our audit to be in line with this guidance, this new guidance, and we've got the FGDP have given us permission to reproduce some of their material in our module as well. So it just got slightly delayed because we were waiting to sort out permission with FGDP, but you've got brand new you'll have a brand new audit and you'll have a brand new module that's coming soon. So I won't go into all of these things, but These are all quotes from inspection reports. So you can see just from a few of these that one practice, the dentist wasn't recording BPE scores. In another practice, X-ray justification findings, so the dentist wasn't complying with IRMA regulations. The dentist isn't following delivering better oral health, so isn't giving smoking cessation or diet advice, all things that you have to do. So our clinical records audit is very, very thorough, and it does check all of these things. So you're going to get an updated audit soon, but make sure you're doing a clinical records audit, that you're doing at least one a year for all your dentists. You're auditing enough records, and your dentists aren't auditing themselves. That's a key thing. Do it as peer review, and people try and find problems, because then you can fix things. Ooh, that slide hasn't quite worked. There we go. Okay, so auditing. A big thing, the number one reason practices are failing inspections is because they are not doing audits often enough. They're not doing it accurately. They're not identifying problems, and they're not dealing with them. It doesn't really just stretch to auditing. This is the whole thing. One of the whole things that's had a big impact on being well led is it's all about quality assurance. And so what is quality assurance? I want to sort of move to talk about auditing but in quality assurance at the same time. It's essentially don't just tick the box. That's, if you're going to take one key message away from today's webinar, this is the most important thing that you can take away, which is don't just tick the box. So essentially, if you're carrying out any audit, a review, a patient satisfaction survey, you're doing some event analysis on an incident or incident analysis, or you're doing a risk assessment, it's not just about doing that task. The whole reason you're doing that task is that if you do it correctly, you're going to identify problems. You need to schedule to deal with those problems, to action those problems. We use to-dos in iComply. You need to resolve them and share the learning with the team. And this is where practices, this is the number one area where practices, I think, are not quite getting it right, because this is what you need to do now. Our iComply practices, you do this, you use to-dos, there's reminders to tell you to schedule follow-up actions. You've got in your meeting minutes, you have action bars in order to schedule things. So we give you multiple ways in code to make sure that you're covering this. So again, key message, quality assurance, don't just tick the box. Okay, so risk assessing. It's not just about risk assessing. I've put risk assessing as the title on this slide, but if we look at what that quote is that's coming from the CQC, it says, ensure an effective system is established to assess, monitor, and mitigate various risks. So there's 2 points here which I want to address, which is, one is the risk assessing thing, just sort of the surface level, but the second level of this is ensure that you have an effective system. That's the governance angle, and that's, if you have an effective system, then you're probably not going to have issues with risk assessing, auditing, HTMI 105, recruitment, because you've got effective systems in place. So I think that's another really key takeaway, is about effective systems. And what is an effective system? Well, an effective system is one that makes sure that you don't miss anything and that you follow up on everything and you've got the information you need when you need it. So if we look at the risk assessment side of that first, again, similarly to auditing, is the person who's doing your risk assessments competent to do your risk assessments if you're using our templates? Do they understand how to use the template? If you don't understand how to use one of our risk assessment templates, then please give us a call and ask us and we'll tell you. But there are one-day courses, I think it's called the IOSH courses, that people can go on. There's a one-day remote learning course that if you've been responsible for risk assessing, maybe you can consider. But if you're doing a risk assessment, then you need to be competent. You need to add or remove risks as applicable to your practice. So if you're using one of our templates, then it's a template. So if one of those risks isn't applicable to your practice, or if you have a risk in your practice that we've not considered, then add or remove. You need to add or remove control measures. We've given you a list of, say, control measures that we think you could have in practice to minimize that risk. but that's a template and you may not have all of them. So you need to add or delete those control measures. So you'll go into, classic one is our information security risk assessment. At the top of it, it says, in order to prevent break-ins in the practice, you have CCTV, perimeter fencing, a guard dog. It doesn't actually say guard dog, but you've got a list of things there that you may have. Now, if you've not got perimeter fencing, take it off. If you don't have CCTV, take it off, or consider an action to add it. Think of it as a suggestion. Is there something that we could do to minimize that risk? Create actions if necessary. Like everything for the quality assurance, it's all about creating actions. And if you're using any external companies, then make sure you read the risk assessment. A number of practices fail inspection because they've had a fire risk assessment or a Legionella risk assessment done. They just put the risk assessment on the folder to show the inspector when they come, but inside that risk assessment is 10 actions that they've never dealt with. So I've mentioned that on many webinars, but I think it's really, really important. Okay, so those are the top 5 reasons. So as I said, I just want to go a little bit deeper on that and look at why those 5 reasons are occurring. And it's about governance and leadership. So if we look at the well-led prompts, as we said, 90% of practices that fail their inspection fail because they're not well-led. So I just want to focus on well-led 1 and well-led 3. Well-led 1, do governance arrangements ensure that responsibilities are clear, quality and performance are regularly considered, risks are identified, understood and managed? So if we just take the top bit of that sentence, do you have governance arrangements? And do your governance arrangements ensure that everybody knows who's responsible for what? And that you're doing all the audits, the risk assessments, the policy reviews, the practice meetings, you're doing all of these things that you have to do when you have to do them, and they're generating the correct actions. And that's where practices are tripping up. Also, on well-led 3, how is quality assurance used to drive continuous improvement? So if you're doing those surveys, those audits, those risk assessments, what happens afterwards? Where's your evidence of what came out of that? What did you do about it? How did you train the team to make sure that problem didn't reoccur? Did you change your policy because the policy wasn't quite working? Are you actually using quality assurance, those audits and those risk assessments, to make improvements in your practice? And do you have evidence of it? So those are the really key important things. And you can see the practices, these are from brand new inspection reports. These are from the last 20 or 30 practices that failed CQC inspections. We had a look at those over the last week or so. And this is what we're now seeing. These sorts of statements are now coming on CQC inspection reports that governance systems were not effective. So the practice had governance arrangements were in place. However, the practice didn't have a structured plan to carry out their risk assessment. So they don't have a comprehensive, a full governance system. They weren't doing regular staff meetings. So they've either got a governance system or the governance system isn't good enough. And the governance system wasn't effective and wasn't embedded. So the team weren't informed of what was going on. It was just probably in the manager's office or something like that. So obviously communication is really, really important. So your team understand that you're having those practice meetings. They understand how your governance systems operate. And and everyone's on the same page. So leadership. So obviously leadership's the other big thing, is that, as registered managers, as principals, as legally responsible people who are responsible for the fundamental standards in the practice, we need to make sure we're giving it enough time and that our team, and we are leading it. So you can see that the top one, it says that the practice owner did not provide effective leadership because he was working every day in surgery and hadn't probably delegated the compliance to a manager. He didn't have a system that allowed him to do that. He was trying to do both, and it just didn't work. You can see ones like the trainee. They didn't like that last one. They said a trainee dental nurse should not be a registered manager because she was a trainee dental nurse and trainee administrator, and she'd just been given compliance. So it's not being given to the right person, or it's not being delegated correctly. It's not being led, and the compliance isn't being governed. Which obviously with iComply, it allows you to do all of that. So why do iComply practices pass? Going on to that last sort of point of why do our practices pass inspection? Why we got this 100% pass rate from the last 12 months or from the last year. I'm going to show you all of this in iComply in a minute for those of you who don't have iComply. I think there was a few of you, but the first one is clear responsibilities. You put your responsible people into iComply, into the responsibilities section. You also put those people onto the documents and you name them. You also train your team every month in meetings who is responsible for what. Your team know who your safeguarding lead is. If you ask anybody in the practice, then if that's been communicated properly, they will know. So you're not going to get different answers. The inspector isn't going to see that the roles aren't clear within the practice. Scheduling. As far as we're aware, we schedule all of the activities that will help you to be compliant. And obviously we're doing all of our research and everything and trying to stay on top of what the CQC are doing so that we can react really quickly and give you those policies and procedures that I was talking about at the beginning of the webinar. Leadership modules and dedicated time. There are leadership modules that can tell you how to be or advise you how to be a better leader in your practice. Obviously the system in itself, following the system will hopefully help you improve your leadership and your management. And dedicated time. Compliance management is around, I don't know, to begin with when you're setting it up, it's around 8 hours a week. You can take it down a bit, but it's a big chunk of a manager's job these days, and people who have iComply are giving it the dedicated time it now needs. You're doing these regular policy reviews. You are looking at iComply most weeks, you're checking your policies, you're following the workflow, and when there are updated policies, obviously we're doing that work, the research team and the writing team are doing that work to give you those updated modules when you need them, and the news to let you know anything that we think you need to deal with right now that can't wait for a policy review. So for example, the access audit that we added a few days ago. Has anyone used the access audit yet? Yes. It's quite thorough, isn't it? All done with an action plan. Well done, Louise. Yeah, brilliant. Okay. I hope you all found it really helpful. You adapted it. That's fine, Leanne. It's a template. That's brilliant. It's great that you adapted it. That's not adapting templates. It could get you in trouble on an inspection. Okay, so the bottom there, I've said, the other reason that practices are passing inspections with us is they're ringing our helpline before they have an inspection and asking us what's going on, or they're using our consultancy services and they're having a health check before an inspection. We had a new member who needed a health check about 2 weeks ago because they were having a CQC inspection last week. I went with another one of our team members and we did a full audit of the practice, and we found some problems that needed to be dealt with in the next 7 days. And I had a call from the principal last week thanking us for identifying these things, because it made the difference she felt between her passing and failing an inspection. So we've got the consultancy services if you need help, and if you get that 2-week phone call and you need some help. We also have the quality practice scheme, which is our new quality practice scheme. We've got practices joining every week at the moment. We did the foundation run last year, and with the quality practice scheme, we log in every 3 months and we check how your iComply is being used, and we write a report to the principal, letting them know whether the things are being done that need to be done, whether the investment's being used, and then once a year we come and inspect you. And we try and inspect in line with what the CQC are looking for at that time, and then when we pass you, we give you a plaque which goes outside, and leaflets. So we're finding a lot of people are joining the quality practice scheme because it allows us to help you to stay on top of it. I'm just going to jump into iComply quickly and just show a couple of these things. Right, okay, so just really quick things. I was just mentioning, obviously, that you could see the CQC have real issues when leadership is not clear and people don't know who's responsible for what. So for those of you who don't know, in iComply we have the team responsibilities section. So you can always go in and you can see, this is obviously all me for this practice, but I could change this to any team members. If I get new team members joining, people leave, we can always adjust these you can always adjust these in the system. But this enables you to just define who's responsible for what from the start, and then obviously you need to put those names into the documents as well. But it's always clear. In iComply practices, we find that people generally always know who is responsible for what. Scheduling. We saw that the biggest issue with being poorly governed is that things get missed. So iComply at its core is a workflow and a scheduling system for the things that you need to do to help you be compliant. So you can see just in a typical month of iComply, we've got an administration step which has the policy reviews that you need to do that month, and maybe things like a satisfaction survey. We've got audits and risk assessments and reminders. So we have the disability access audit in this month, and we've got our HTMI 105 validation is due for our autoclaves, and then we've got a practice meeting to give our team all of that information, to set actions, to help them, to help the practice be compliant, to give them the information to pass inspection as well and talk to inspectors. In month 2, you can see we've got the infection prevention audit there, health and safety risk assessment. This practice's employer's liability insurance is due then, and we've got a practice meeting again. So iComply is very, very clear. It's quite clean. It shows you what you need to do, gives you the documents to do it, tells you what to do with them, and tells you where to file them. So you can see fire risk assessment, CPR training. I won't show any more of that, but it schedules it very clearly for you. So if you follow it, then hopefully you're never going to miss anything. You've got the leadership management modules and the time. Obviously, we talk about when you're first starting out with iComply, you probably want to spend about 8 hours a week for the first few months, and then you can scale down. You've got the policy reviews. So if we jumped into any administration step, I'll go to the, might as well go to the beginning of iComply. And what you'll see is down here, you've got, say, something like the patient consent policy and procedure. And for those of you who don't know, I'm sorry, for people who've got iComply, you already know this, but whenever you're being asked to do anything, you've got the related templates link where you've got the document that you need to use. So inside this activity, we're being asked to deal with the consent policy, and here we have the consent policy, and we can also see what version number it is, which is really important. We can see what version number it is, so we know whether or not we need to update from the version number we have on file. And obviously, the subscription with iComply is helping to support you, because we are researching and updating those version numbers and making sure that you've got the latest policies and procedures when you need them. Obviously, you also mentioned the news section. So for those of you who don't know, when you log into iComply, so I'll click on the dashboard. Oh, did I not click that? There we go. Okay, so if we're on the dashboard right now, you can see we've got the news section here. So if something can't wait until you've got a policy review, if there's something we want you to know about right now or a document we'd like you to use, we put it in the news section. So you can see here, we added the new audit of disability access. So we put that in there. When we release sedation documents, they will go in there. When we update the clinical records audit, which is coming soon, you'll see that that will be there as well. So we won't wait for your annual review of that topic. We'll put that in there for you. And obviously anything else that we see coming out, like maybe this CCTV policy or risk assessment that we might need to introduce, that will be in the news section as well. So just keeping you up to date. The other bit is obviously where practices are failing this inspection, where practices aren't passing, as I said, it's 90% is about being well led. So in iComply, well, as you're completing stuff and you're signing stuff off, which I really, really strongly recommend that you do, is you actually use the system to sign them off as well, because every time you sign something off, you're date stamping it and you're showing how you've met a key line of inquiry. So if the CQC come in and they're wanting to see how you're well led, obviously you can show them iComply and show them all the scheduling, and you can show them the responsibility section, and that the leadership is really clear and everyone knows who's supposed to be doing what. But the other thing that you've got is you've got the compliance report. So you can just jump to the compliance report, click on inspection prompts, filter it, and click on the well-led key line of inquiry and apply the filter. And what you can show them is exactly, for those of you who don't have iComply, When you sign it off, it will appear here with any notes that you've added, and where it says completed, it will put in the date when you completed it. So this will be filling with your notes as you're doing stuff in iComply. But you can see, you can show the inspector all these things that you are doing. You know, all of these things that you've done in the last 12 months, and the practice meetings, and the risk assessments and audits, everything you've done to demonstrate that you are well led. And the reason we know that is because the CQC won't tell you what you need to do exactly to be well led, but when you've read 1,500 inspection reports and you look at what they look at under well led, at Code we know what they're looking for. So we make sure that the report will demonstrate that for you. So I just wanted to show everybody that, just to show you how the system helps you to do this, to be well governed and to be well led. That is the end of the webinar for today.